Okay, so good afternoon, everyone. My topic this afternoon is called an unusual suspect. And let us begin. Okay, so we'll begin with a case of a 35-year-old man. The background is that of HIV positive on ARVs, who was virally suppressed with a CD4 count of 468. This was in March this year. There's also a history that he was previously on TB, but it's not quite clear and it's not known when. He was admitted to the Khumalo cardiothoracic team in April with a diagnosis of heart failure secondary to infective endocarditis. On echo, these were the findings. He had severe mitral regurgitation with the vegetation, as well as prolapsed posterior leaflets. He had moderate to severe tricuspid regurgitation, and he still had preservation of the ejection fraction. So the plan for this gentleman was that he needed a mitral valve replacement, as well as a tricuspid annuloplasty. These were the blood results and lab results taken around the time of admission. And of course, in the workup of endocarditis, we always recommend highly that clinicians take blood cultures. And as you'll see here, this patient had 3 negative blood cultures in the workup of endocarditis. So he was then, of course, scheduled for theater, and intraoperatively severe mitral regurgitation was found with vegetations on both the anterior and posterior leaflets. He also had severe tricuspid regurgitation and annular dilatation, and mitral valve tissues were taken to the laboratory for MCNS as well as for 16S RNA PCR. And of course, a mechanical valve was placed in situ. So now, who do you suspect? We're sitting with a young man, heart failure, what's presumably culture negative endocarditis. Any takers out there for possible pathogens?
Harry, please go ahead.
Thanks, Prof. Thank you, Amanda. So I just got a question. Was there any antibiotics given prior to the blood cultures taken? Because is it a true culture negative endocarditis?
No, I chatted with the cardiothoracic reg who was overseeing it at the time, and they were quite strict about taking all of them prior to commencement of antibiotics.
Okay. So I guess if we've excluded that and gone into the history well, then we could possibly call this a culture negative endocarditis, and then the most common cause would probably be the Bartonella bacteria, and then probably followed by Coxiella burnetii. Other bacterial causes that are much less common, I mean, you could that are culture negative could be Mycoplasma, Legionella, fungal causes, obviously. I know we probably would have cultured them if extended cultures were done, but got to take that into consideration. And Canada would be up on the list as well. But I don't think he's got any risk factors for Canada. And then you could think of, I forgot other bacterial causes such as higher order bacteria. So your Mycobacterium tuberculosis would also be a cause, especially in our South African environment.
Great. For time, we're going to go back to you, Amanda. But thanks, Terry.
Thank you.
Thanks, Terry. Thanks, Prof. Those are some good answers, Terry. But remember, the topic is an unusual suspect. So we're looking at something a little more rare and not seen as much. So on the 16S, we identified a Dietzia species from the mitral valve leaflets. And the sequence homology was 99% homologous with Dietzia timorensis. So Dietzia species, these are organisms that are from the family Dietsiae, the suborder Corynebacteriinae, and order Actinomycetales. The name of Dietzia was given to these organisms in honor of a very accomplished microbiologist in America called Alma Dietz. So if you're still thinking, what is Amanda talking about? This is a lovely schemata that's found in the Kahneman textbook that looks at the aerobic actinomyces in terms of their acid-fast ability. So as you can see, on the one side is Mycobacterium, which we know is obviously positive, and then partially acid-fast, separated into whether there's absence or presence of an aerial mycelium, there's nocardia, and absence right there at the bottom, as you'll see, is Dietzia. That's where Dietzia belongs. Okay, so the genus Dietzia was first assigned in 1999 by Rainey et al. To organisms that were previously classified as rhodococci. These organisms have a worldwide distribution. They're found mainly in the environment amongst soil and plants, and can also be found amongst the digestive tract of animals like dogs and fish. They actually have a lot of applications in different industries. For example, the production of carotenoids, the biodegradation of petroleum and crude oil. And interestingly, I found that they're also used as a biotherapeutic agent in treating TB or paratuberculosis, pardon me, in adult animals. That was quite interesting to me. In some of the texts, they are described as emerging pathogens, and in some of them even as opportunistic pathogens because of their association with immunocompromised patients. What is known at this point is very little in terms of virulence factors, in terms of what allows them to cause infection. So in the past, most of Dietzia species were misidentified as members of the Rhodococcus genus, but now with molecular methods, there's more and more of these organisms being recognized and the genus is expanding. These organisms are uncommonly isolated in the labs and rarely encountered in clinical practice as compared to their cousins, the other aerobic actinomycetes. It's a diverse group of bacteria, although difficult to identify, and commonly if you don't have an index of suspicion, you'd sign out the result as possible contaminant. Okay, clinical features. I've got a table coming up to look at all the various cases that I found out there, but these are some of the main clinical features where they've been found to be significant: bloodstream infections, device-associated infections, prosthetic joints, and even skin and soft tissue in dog bites, and also as a colonizer in healthy skin. That's quite interesting. Right, so looking at the laboratory diagnosis, as you can see, there's a beautiful gram stain there showing gram-positive bacilli that are small. The Dietzia are known to form rods, short rods, and even coccobacilli, which actually isn't a term we use quite often with gram-positives in themselves. They also demonstrate V-forms, as you can see here in the bottom right corner, and they can also do snapping elongation and are acid-fast negative. Okay, we've already spoken about this slide. And with regards to culture, these are slow-growing organisms with fine growth being seen after 48 to 72 hours of growth, which sometimes if you're not having a prolonged incubation of your plates, you can miss them. They grow across various different types of media and are pigmented, as you can see in the photo there, from orange to pink and coral red. They don't produce aerial hyphae, grow under aerobic conditions and across a wide variety of temperature ranges. If you just look over here, the Rhodococcus is quite similar to all these other ones as well. I mean, if you had a culture plate without the names, you wouldn't really know which one is which. Just to mention that species that have been found a lot in human isolates is Dietzia maris, Cinemea, and papillomatosis. Okay, here this table is just to show Dietzia in relation to the other aerobic actinomyces in terms of the features. As you said, it can be pigmented. Here they say yellow, coccobacillus, acid-fast negative, and interestingly, they have no growth in lysozyme, which is a factor that you can use for nocardia to differentiate, because nocardia can grow in lysozyme where Dietzia doesn't. Okay, identification methods. The Coraini API can be used, which is basically a commercially available kit that looks at different substrates and how the organism utilizes or reduces them. Substrates, for example, like nitrates, reduction, hydrolysis of urea, the use of carbons as a sole source of energy, and nitrogen as well. The issue with the Coraini is that earlier versions were really bad at identifying Dietzia to a genus level. And with regards to Vitek, the Dietzia is not present on the ANC card at all. Okay, so this table is taken from a study that was performed in Spain in 2010 This was over a period of 5 years where 15 isolates of Dietzia were collected from human clinical samples from a hospital in Spain that were identified as Rhodococcus equi by the Corani API. And with 16S RNA gene sequencing, 7 of them were conferred to be true Rhodococcus, whereas the rest were actually members of the Dietzia species. So just interesting to see, again, how one technology for identification wasn't as great as the other. Okay, moving on to more exciting ways of identifying organisms now, the comparison of the Vitek MS and the Bruker Multi-TOF methods. With this study, we evaluated the performance of the Bruker versus the Vitek, and they had a collection of 154 isolates that were identified as Rhodococcus equi, and in there also was some Dietzia as well. And the gold standard, they did a PCR amplification of the CHO-E gene and 16S RNA sequencing as well as the gold standard. And they found basically that the Bruker identified 85% of the isolates down to species level, whereas the Vitek MS identified 84%. What was noted is that the two systems allowed differentiation between Rhodococcus and Dietzia, but in order to get species level identification of Dietzia, 16S proved to be a better tool. So moving on to susceptibility testing. So the recommended method is broth microdilution, according to the CLSI. UCAST doesn't have any recommendations for these organisms at all. The agent of suspension of use is the cation adjusted Mueller-Hinton broth, and culture must be taken from either blood agar or trypticase soy agar plate. Organisms must be incubated for 3 days. That's usually unusual. I mean, if you think of broth dilution, it's usually an overnight. So 3 days, at which point they can be read, sometimes even up to 5. I've read sometimes up to 5 days at 35 plus minus 2 degrees. And in terms of agents, they've got 2 categories, primary agents and secondary agents that one can test. Looking at primary agents, this is taken from the CLSI, with looking at the MIC categories, the breakpoint categories for primary and the secondary agents as well. Of interest is that ceftriaxone is less than 8, which is a common breakpoint that we use a lot for, not breakpoint, and it's not 8 being common, but ceftriaxone, sorry, being a common antimicrobial that we consider use of. Okay, so in terms of management, there's a paucity of data in terms of managing these cases out there. It's limited to a lot of case reports and a lot of case series, and there are no antimicrobial recommendations or guidelines that are available. So what I did is put together a table of all the cases that are have been reported till date, and just to look at the organism isolated, the source of the organism itself, and of course, how the patient was treated and the outcome. And the general thread throughout all of them is that many of the patients got beta-lactam in their management, and the great majority of them did well. The first isolated case, 99, this was a blood culture, catheter related. The patient was on penicillin and was discharged and did well. And as you go through the list, there's all these interesting cases. One was a prosthetic joint, was treated with teicoplanin. Here is one of aortic and pericardial specimens in a patient with aortitis who unfortunately died in theater on the table. This was very interesting as well because they took skin swabs of healthy patients and also of patients with atopic dermatitis. And it was found that healthy patients can also be colonized with the organism as well. It's been identified in the perianal swabs in bone marrow transplant recipients. Also in patients with confluent reticulated papillomatosis, it's been identified as well. And there's also one of a endocarditis. Did I add it here? Yes, a pocket infection. This was a gentleman who had a pacemaker, had pocket sepsis and endocarditis subsequently, and was treated with Fluclox and had a good recovery. So just a spread of all the reported cases out in the literature. So to go back to the actual case, this patient post-op, he did well, was uneventful. The period of post-op, He was treated with ceftriaxone and doxycycline for 6 weeks and discharged to cardiology. So just in summary, a case of endocarditis with an unusual organism, which I think he probably did well because he was on ceftriaxone and probably was susceptible. Thank you very much.
Amanda, thanks very much indeed. A wonderful case. And if you could just stop sharing your screen, and if we could see you, that would be fantastic. So this is, yeah, so very interesting. A question just in terms of optimal treatment. I mean, because of its similarity to Rhodococcus equi and the fact that there is some evidence for treatment in Rhodococcus, I mean, would you not go for combination therapy that you might use for Rhodococcus?
So in reading around the subject of, it seems like a lot of the antimicrobial regimens were beta-lactam based and tended to be either single or double agents, but there isn't really anything tangible to say that dual therapy is better or not. A lot of them were case reports, so it's really just what happened and how the patient, what the outcome was. So I guess there could be a case to do dual therapy or also a beta-lactam based regimen.
Okay, so I mean, because my understanding from within Rhodococcus is that you either use a beta-lactam and a glycopeptide, or you would use perhaps a quinolone and macrolide and rifampicin, but that you're saying there's no good evidence for that, or it's not close enough to the Dietzia to suggest that.
Yeah, there's hardly much in the way of recommendations for treatment in itself, in that those few cases that I showed in the table were all that's been published since 1999 till 2017. So not much in the way of evidence. Okay,
can I ask, so Lucille, I think we've still got you on the line, and I think you did a very in-depth study in Dietzia, endocarditis. Do you want to comment?
I think you might have the wrong person, Mark. Absolutely never.
Oh, I'm sorry.
I don't remember doing it. But thank you for asking.
I do apologize. Any comments on the case? Very interesting case, I thought.
No, I don't have any comments.
Okay.
And no
Adrian is okay. Adrian is head of microbiology. Your thoughts?
Yeah, Mark, I think it's a tricky issue. I'm not sure how to answer that question. I think it would depend very much on how the patient responds, if they're persistent blood cultures. I mean, one assumes the surgery is the major intervention. So, you know, irrespective of what you're going to give, source control would probably do it.
Okay, so Amanda, any final thoughts on this? What's your main take-home message for us on this very unusual case? And Tari has obviously added it to his list of differential diagnoses, etiological diagnoses.
Sorry, before.
Oh, sorry, Sipo,
yes, I had my hand up.
Oh, I'm sorry, I can't see it.
Yes, the question really revolves around: is this organism quite different from Rhodococcus, or is it similar? Because you know, you said it was classified as Rhodococcus, but the question is it, you know, a completely different species?
Yes, it is a completely different species in itself, with a lot of growing subspecies being identified, you know, as obviously molecular as becomes more important. But I think the thing is, it is very closely related, which is why a lot of the more limited identification systems tend to default to identifying it as Rhodococcus instead of Dietzia itself.
Okay, I'm sorry, I can't see people's hands. So if anybody else has a hand up, please, please do ask. Otherwise, if not, we are. Sorry, and your comment.
Yes, he said my closing statement.
Yes, your closing statement, please.
My closing statement is just to consider it in where you might see obviously pigmented colonies, and because of its slow growth, this is a place where prolonged culture is really recommended.
No, thank you. No, that's wonderful, and really appreciate a great case presentation. I think so wonderful that it deserves some heating to be supplied to Amanda's office, Professor Brink, so that she doesn't have to present in hat and coat, because it's obviously very cold in C18. Okay, so
I'm a Durbanite, always cold.
you're a Durbanite, always cold. Okay,